Assalamu alaikum. It's a new journey of pediatric gastroenterology. Let's dive into it. Before jumping into the pediatric gastroenterology part, I would like to show you a video. Can you diagnose this patient? Look at this. Okay, now we know that liver ultrasound is indicated for hepatomegaly if liver age is more than 3.5 centimeter in neonates, which can be suggestive of cholestasis or CHF, Okay, now tracheoesophageal fistula. TEF, tracheoesophageal fistula. Tracheoesophageal fistula with esophageal atresia. In here, what happens? There is defective division of the foregut. There are three gut, like foregut, midgut, and hindgut, and foregut failure of division, defective division into the esophagus and trachea. Division of foregut into esophagus and trachea. Most commonly results in proximal esophageal pouch and fistula between the trachea and the esophagus. Clinical feature is coughing, choking, vomiting with feeding. Coughing, choking, vomiting with feeding, excessive oral secretions, and commonly part of the vertebral, anal, cardiac, tracheoesophageal, renal, and limb association. Diagnosis is NG tube placement, inability to pass the enteric tube into the stomach. Inability to pass the enteric tube into the stomach is the first line, uh, and in X-ray you will see the enteric tube coiled in the proximal esophagus. In X-ray, you will see an enteric tube coiled into proximal esophagus. Management is surgical correction and vectoral screening, echocardiography, and renal ultrasound. Okay, in utero, the affected fetus is unable to swallow the amniotic fluid, often causing polyhydramnios on prenatal ultrasound. Up to 50% of the patient with tracheoesophageal fistula with esophageal atresia have other congenital anomalies such as bacterial association. Tracheoesophageal fistula with esophageal atresia is less commonly associated with the charge syndrome. There are three types. There are mainly five types of esophageal atresia with tracheoesophageal fistula. This is esophageal atresia with distal fistula. Isolated esophageal atresia. H type esophageal tracheoesophageal atresia. H type tracheoesophageal atresia. Esophageal atresia with distal fistula, it is the most common. And esophageal atresia with proximal and distal fistula, and finally this one, esophageal atresia with proximal fistula. Look at the thymus. This is the orogastric tube, this is the endotracheal tube, this is orogastric tube, endotracheal tube, this is thymus. This is a picture of the, in the X-ray you will get enteric tube coiled in the proximal esophagus. There is enteric tube coiled in the proximal esophagus. Esophageal atresia, distal esophagus. Okay, and look at this congenital umbilical hernia. Umbilical hernia, incomplete closure of the abdominal muscle. There is incomplete closure of the abdominal muscle. soft non-tender bulge at the umbilicus, it protrudes with increased abdominal pressure, and it is typically reducible. Management often for spontaneous closure and elective surgery at around age 5. Observed for spontaneous closure and elective surgery at around age 5. It is commonly associated with hypothyroidism, Ehlers-Danlos, Beck with Wiedemann, and Down syndrome. It is commonly associated with hypothyroidism, Ehlers-Danlos, Beck with Wiedemann, and Down syndrome, but also occurs frequently in normal newborns. Small umbilical hernia closes spontaneously. Spontaneous closure is less likely if the hernia is more than 1.5 centimeter in diameter. Mm, with underlying medical problems, surgery is recommended around age 5. Surgery is recommended around age 5 for persistent hernias, or sooner if complications occur. Abdominal ultrasound is often performed in an older child or adult when an acquired umbilical hernia is suspected. A congenital hernia is diagnosed clinically. Immediate surgery is performed for gastroschisis and omphalocele. Immediate surgery is performed for gastroschisis and omphalocele. An umbilical granuloma in newborns after the umbilical cord has separated moist, red, pedunculated, friable masses. This is gastroschisis and omphalocele. Before jumping into those things, look at this picture first. Evisceration of the bowel wall with no covering. In here, evisceration of the bowel, there is no covering, and it is lateral to the umbilical cord left of the defect. This is umbilical cord at apex and covering membrane, and sac containing multiple organs. Gastroschisis, there is paraumbilical herniation of the abdominal content through abdominal wall defect, and in omphalocele, herniation of the abdominal content through umbilicus. There is herniation of the abdominal content through umbilicus. Gastroschisis, it is not covered by the peritoneum and the amnion, and omphalocele, it is covered by the peritoneum and amnion. Midline membrane covered. Gastroschisis not covered by chromosomal abnormality. Good prognosis. Omphalocele, it is associated with trisomy 13, 18, Beck with Wiedemann and cardiac G and neural tube. Beck with Wiedemann syndrome. Dysregulation of the imprinted gene expression. Deregulation of imprinted gene expression on chromosome 11p15. There is fetal macrosomia, rapid growth until late childhood. Omphalocele or umbilical hernia, macroglosia, hemihyperplasia, and hypoglycemia. Complication is Weems tumor and hepatoblastoma. Surveillance in serum, alpha fetoprotein, and abdominal or renal ultrasound. Most patients have sporadic or inherited alteration of chromosome 11p15, which includes a gene that encodes the insulin-like growth factor 2. Newborns must monitor closely for hypoglycemia because fetal hyperinsulinemia can result in profoundly low blood glucose at birth. Abdominal ultrasound and alpha fetoprotein level testing should occur every 3 months from birth to age 4, and renal ultrasound every 3 months from the age 4 to 8. Okay, before jumping into this, pyloric stenosis is commonly present on age 3 to 5. There is postprandial projectile vomiting, So hungry vomiter, infantile hypertrophic pyloric stenosis, firstborn baby, feeding, bottle feeding, risk factor is EF, that means erythromycin, and there is forceful non-bilious imaging. So firstborn baby feeding, bottle feeding baby, firstborn baby, bottle feeding baby, erythromycin is one of the risk factor, and projectile forceful non-bilious emesis. Or weight gain, dehydration, olive shape, abdominal mass. Diagnostic studies: hypochloremic, hypokalemic metabolic alkalosis, hypochloremic, hypokalemic metabolic alkalosis. And there is thickened pylorus on abdominal ultrasound, intravenous rehydration and pyloromyotomy, Intravenous rehydration, normalization of the electrolyte or and correction of the alkalosis prior to surgery have been shown to decrease the risk of postoperative apnea and improve overall outcomes. Evaluation of biliary emesis. Biliary emesis, first, stop feeding. NG tube decompression, stop feeds. NG tube decompression and IV fluid. Uh, Biliary emesis, stop feeds, NG tube decompression, IV fluid. Abdominal, then you do the abdominal x-ray. In abdominal x-ray there is free air hematemesis, unstable vital sign, free air hematemesis, unstable vital sign, surgery. Dilated loops of bowel, do contrast enema, microcolon, meconium ileus, and if there is rectosigmoid transition zone, it is Hirschsprung disease. Rectosigmoid transition zone, it is Hirschsprung disease. NG tube misplaced into duodenum, upper GI series. There is ligament of Tracheoesophageal on the right side of the abdomen, malrotation. So misplaced NG tube is misplaced duodenum, do upper GI series, ligament of the Tracheoesophageal on the right side of the abdomen, malrotation, and double bubble sign is the duodenal atresia. I remember double bubble sign very well. Double bubble sign, duodenal atresia, duodenostomy. These are the thing you need to remember. NG tube misplaced into the duodenum, upper GI series, ligament of Tracheoesophageal on the right side of the abdomen, malrotation, and dilated loops of the bowel, contrast enema, microcolon, meconium, rectosigmoid junction, Hirschsprung, free air, hematemesis, unstable vital signs, surgery. Okay, if we look at this again, biliary emesis, unstable emergency laparotomy, if it is stable, free air under the diaphragm, urgent laparotomy, dilated loops of small bowel, increased rectal tone and or delayed passage, of the meconium, yes, increased rectal tone in the and or delayed passage of the meconium, yes. In contrast enema, if there is a microcolon, that is meconium ileus. If there is rectosigmoid transition zone, that is Hirschsprung disease. Contrast enema, microcolon, meconium ileus, rectosigmoid junction transition zone, Hirschsprung disease. If it is normal, upper GI series, right sided ligament of Tracheoesophageal and malrotation. Normal upper GI series, right sided ligament of Tracheoesophageal, malrotation. If there is double bubble sign, duodenal atresia, This is Hirschsprung disease. So there is clinical feature of bilious vomiting, abdominal distension, failure to pass meconium, and failure of the internal sphincter, anal sphincter relaxation, tight anal sphincter. There is increased megacolon. Look at these. There is increased megacolon. Colon is increased. There is aganglionic segments, lack nerves, and causes distal intestinal obstruction. If you look at this sigmoid colon, rectum, anus, this is normal. enlarged colon, megacolon, aganglionic segment. Okay, now Hirschsprung disease versus Meconium ileus. Hirschsprung disease, failure of the neural crest migration. In Hirschsprung disease, there is failure of the neural crest migration, and Meconium ileus obstruction by its visceral stool. Hirschsprung disease is rectosigmoid junction HR and Meconium ileus MI. Hirschsprung disease, there is increased tone and positive squid sign, expulsion of the gas or stool on theory. Meconium ileus normal tone, negative square sign. Meconium ileus MI, ileus ileum, Meconium ileus ileum MD, dilated bowel, small bowel on imaging, and in contrast there is microcolon. On X-ray there is dilated small bowel, and on contrast there is a microcolon, and it is cystic fibrosis. It is associated with cystic fibrosis. And Hirschsprung is HD, like Hirschsprung associated Downs, so dilated proximal colon and small bowel, and meconium consistency is normal. And meconium ileus, hyperosmolar anemia, and surgical management. Hirschsprung disease, failure of the neural crest migration to the distal colon, delayed passage of the meconium, bilious vomiting, enterocolitis, children, adolescent, chronic constipation, failure to thrive. There may be distended abdomen, tight anal sphincter. Most important is rectal suction biopsy is a gold standard, and anorectal manometry contrast enema is adjunct. Surgical resection of the aganglionic segment. Surgical resection of these aganglionic segment. This is congenital aganglionic megacolon. There is no air in the there is no air in the rectum. Look at this picture. There is no air in the rectum and dilated small bowel loop. If we see this picture, there is abrupt transition. There is abrupt transition, dilated descending colon, abrupt transition, normal sigmoid junction, normal sigmoid junction. This is Hirschsprung disease, markedly dilated bowel with proximal distension, markedly dilated bowel with proximal distension, and narrow transition zone in rectum, and this narrow transition zone in the rectum and distal sigmoid colon, distal sigmoid colon. Meconium ileus may be the earliest feature of cystic fibrosis, may present in the first couple of days in the life with abdominal distension and failure to pass the meconium. Imaging of the meconium ileus classically reveals dilated loops of small bowel proximal to the obstruction with minimal or absent air distally in the colon and the rectum. A soap bubble gas pattern may be present in the ileum due to mixing of meconium ileus with air soluble contrast enema revealing the microcolon. This is meconium ileus, this is microcolon, meconium plaques, this is contrast enema demonstrating meconium plaque. Duodenal atresia, double bubble sign, polyhydramnios, Downs association, duodenal atresia, fluid filled proximal duodenum, fluid filled proximal duodenum, and fluid filled stomach, abdominal pocket 10.1 centimeter, jejunal atresia, triple bubble sign, malrotation. There is intermittent volvulus. In malrotation, there is intermittent volvulus. Duodenal obstruction is caused by the Ladd's vent of the Ladd's vent fibrous peritoneal tissue cross the duodenum. Okay, now neck, very high yield, necrotizing enterocolitis, gut wall, gut mucosal wall invading the gas producing bacteria, intestinal inflammation and necrosis, a prematurity, hypotension, congenital heart problem, very low birth with less than 1.5 kg, enteral feeding, non-specific apnea, lethargy, vital sign instability, gastrointestinal abdominal distension, feeding intolerance, Biliary emesis, feeding intolerance, biliary emesis, there is bloody stool. These symptoms are usually preceded by non-specific lethargy, vital sign instability, and hypothermia. In X-ray show pneumatosis intestinalis, they are in the bowel wall, and there is pneumoperitoneum, free wall under the diaphragm. Free wall under the diaphragm. Complication is sepsis, DIC, late stricture short bowel syndrome. Screening imaging is not recommended in preterm infant. This is neck. There is curvilinear lucency. Look at this picture in the brief. There is curvilinear lucency. There is curvilinear lucency. There is curvilinear lucencies with bowel wall pneumatosis intestinal curvilinear lucency in the curvilinear lucency within the bowel wall pneumatosis intestinalis and pneumoperitoneum here in the peritoneum, pneumoperitoneum. These are the two feature. Pneumatosis intestinalis. Look at this pneumatosis intestinalis. There is red arrow. In addition, portal venous here. There is portal venous here. Okay, management of necrotizing enterocolitis, discontinuation of the enteral feeding, nasogastric decompression, blood culture and empiric, antibiotics, IV fluid repletion, serial, complete blood count, electrolytes, serial, abdominal examination and imaging. There will be bowel perforation, pneumoperitoneum, clinical deterioration, vital sign instability, persistent acidosis, despite medical management suggestive of a bowel necrosis. Immediate management of neck is bowel rest, empiric broad spectrum antibiotic. Response therapy is monitored via serial blood work and abdominal examination. Surgical intervention is reserved for bowel perforation. Then these food, milk, protein induced allergic proctocolitis. Their family history of allergy, eczema, and asthma. There is well appearing painless. There is well, sorry, there is well appearing infant with painless bloody stool. It is elimination of treatment is elimination of the milk and soy from the maternal at very high yield. It is in the question stem that like the baby comes to you, well appearing baby comes to it with a painless bloody stool. When you see blood, you get become nervous. You got nervous. That why blood? So it is not due to very emergency situation. It is just a simple thing like if you eliminate the milk and soy from the maternal diet in the breastfeed infant, then it can be corrected. And hydrolyzed formula containing pre-digested protein in the formula fed in infant. Spontaneous resolution by age 1 year. Patients should be reassured by the prognosis is excellent. Almost all affected infant can tolerate daily or soy product by age, daily or soy product after age 12. It's a non-Ig mediated reaction in which a patient in the infant's diet breast milk or formula milk causing eosinophilic inflammation of the distal colon, inflammation of the distal colon and the rectum. Cow's milk, whey, soy proteins are most frequent triggers. Diagnosis is clinical confirmed when bleeding ceases after maternal dietary modification. Visible bleeding should be resolved within 3 days, but occult bleeding may persist up to 2 weeks. Most breastfed infant response to the maternal elimination of the dairy alone. Additional soy usually recommended only for persistent symptom to avoid the severely restricted maternal diet. In rare, persistent bleeding is present. IG and non-IG mediated. IG mediated is anaphylaxis, urticaria, vomiting, and non-IG mediated food protein induced allergic proctocolitis. There is painless bloody stool, and non-IG mediated food protein induced enterocolitis symptom usually less than 12 months within hours, profuse vomiting, diarrhea, dehydration, lethargy, and ill appearing. This is for food protein induced allergic proctocolitis. Breastfeeding eliminate a common trigger from the maternal diet, dairy, soy. Symptom resolution, yes. Food protein induced allergic proctocolitis confirmed. Reintroduced offending protein around age 1. No. Consider evaluation for alternate diagnosis using flexible sigmoidoscopy. Food protein induced allergic proctocolitis formula feeding. Formula feeding, switch to hypoallergic or hydrolyzed formula. Symptom resolution, then the reintroduce of the authentic protein around age 1. Okay, okay, this topic is a very wonderful. Okay, crying in young infant. Intermittent inconsolable less than 3 hours per day. Intermittent and inconsolable less than 3 hours per day. Colic. Colic is more than 3 hours per day, usually evening, and more than 3 days per week. Okay.